Hello ladies and gentlemen, and welcome to set 4 of our internal medicine review questions. Just to preface, if you like these videos and want to see more, please consider subscribing to my Patreon page at www.patreon.com/pwbmd. Consider chipping in $1 a month. A little bit goes a long way to help keep these videos free and coming. If you subscribe, you'll have access to some of my premium videos in which I go over case studies, how to formulate differential diagnosis and treatment plan, things that will come in handy for you in real life, in your practice, and particularly as you get ready to study for Step 3 of the USMLE. Thank you very much in advance for your consideration. Question 1 gives us a 46-year-old man presenting to the ER complaining of swelling, quote-unquote swelling, of his abdomen, which has been worsening over the past week. He is unable to fit into his shirts. He was seen in the ER 9 months ago for hematemesis and underwent variceal banding. During that time, his AST and ALT were found to be elevated. He failed his follow-up appointment, and this is the first he has been back to the doctor. He smokes 1 pack per day for the past 25 years and drinks 6 to 8 shots of vodka every day for the past 20 years. Physical exam reveals a distended abdomen, fluid wave, and skin findings. No jaundice. Vitals are stable and within normal limits. Which of the following is the most appropriate next step in management of this patient? A. Spironolactone. B. Furosemide. C. Disulfiram. D. Therapeutic paracentesis. Or E. Low sodium diet. And I'll just add here that this is the skin findings that we see on this patient. So I'll give you a chance to pause here. And the answer to this question is A. Spironolactone. What is our presumptive diagnosis in this patient? We have a 46-year-old guy, relatively young, and he has swelling of his abdomen, but when we look at the exam, of course swelling is what he says. When we do the physical exam, we find a fluid wave, and a fluid wave is consistent with ascites. There's fluid in his belly, in the peritoneal space. This skin finding is consistent with a spider angioma. Spider angiomas form because of increased estrogen, which is consistent with liver failure. Liver failure is going to happen in this patient because he's probably got cirrhosis from long-term alcohol abuse. And that's what causes the spider angioma. Spider angioma are also seen in pregnant women occasionally, and that is because of the higher levels of estrogen that accompanies the pregnant state. So this patient has uncomplicated ascites. He doesn't have fever, so we're not thinking of like an infectious ascites. He doesn't have really any other symptoms other than just the ascites. And the first treatment, the first step in the management of the treatment for ascites is spironolactone. What are these other drugs? Furosemide would be a reasonable choice. If we have the patient on spironolactone, we could add furosemide if the spironolactone is not enough, and we'll go over that in a little bit. Disulfiram, what is that? That's antabuse. Antabuse is something you give a patient if they agree. You don't just give it to them. You give it to them if they agree, and it's sort of a negative incentive for them to drink, because if they drink alcohol with disulfiram, then they're going to get really sick. And so sometimes this is good for patients who are long-term alcoholics who are coming out of treatment, out of detox. You can give them disulfiram to keep them from drinking if they agree to it. You wouldn't want to do that in this patient anyway. It would be highly unadvisable for him to just give up drinking cold turkey. Remember the potential for delirium tremens with acute alcohol withdrawal. And so in this patient, you may want to give a benzodiazepine, something like chlordiazepoxide, otherwise known as Librium, to prevent delirium tremens if he goes off the alcohol cold turkey. So you would not want to give disulfiram in this patient. Therapeutic paracentesis would be a possibility down the road, but this is something that we reserve for ascites that doesn't respond to medical treatment. And a low sodium diet would be advisable in this patient, but he certainly needs medical management. So what is ascites? Plainly put, ascites is the buildup of fluid in the peritoneal cavity. Remember, the peritoneum, the peritoneal cavity, is this potential space, and that potential space can be filled up with air, it can be filled up with fluid. And when you have fluid in that potential space, you get this big swollen belly. and you'll be able to appreciate that fluid wave when you do your physical exam. That's what ascites is. And ascites is a major complication of liver disease. Now, ascites, fluid in the peritoneal cavity, can be from a transidate or an exudate. What are transidates and exudates? This is very important, so I want you to listen up here. A transidate is due to increased pressure in the portal vein. What's the portal vein? Remember, the portal vein is the vein that goes into the liver. It's a vein because it's got deoxygenated blood. So here you have this vein that goes into the liver, and this vein is going to split up into venules, and those venules get really, really, really small, and it can exchange the blood can get detoxified in the liver, and because those vessels get really small, they can be damaged if the hepatocytes are damaged. And what happens if they're damaged is that the blood can no longer move freely through the liver and ultimately into the hepatic vein. And the hepatic vein drains, there's two of them, right and left, and that drains into the inferior vena cava. So you have the portal vein, which goes into little tiny venules, and then that ultimately drains into the hepatic vein. Well, if you have cirrhosis, you block off those little tiny venules, and that's going to increase pressure in the hepatic or in the portal vein. So if you increase pressure in the portal vein, now you have this increased hydrostatic pressure, and that's going to push fluid out as an attempt to relieve that pressure, and that's a transidate. And so the number one cause of a transidate of ascites is cirrhosis. Now you can also get this from other things that would increase pressure in the portal vein. Heart failure can do that. If the portal vein is occluded, either from anatomic reasons or from a compression from like a tumor, for instance, that can raise the pressure in the portal vein. Nephrotic syndrome for other reasons, but in this case, you would have decreased protein in the blood, and that's going to cause hydrostatic pressure. Because of decreased protein, you're going to have a movement of fluid into the peritoneal cavity. And then low protein malnutrition for a similar reason. You see those kids with kwashiorkor that are in developing countries that are starving. You see them with their big bellies. That's not fat, that's actually ascites. So that's a transidate. It's caused by increased pressure in the portal vein. An exudate is caused by sort of an osmosis of fluid into the peritoneal cavity, and that's because stuff gets in to the peritoneum. So if you have cells or anything really in the peritoneal cavity, it's going to pull water in as a sort of osmotic effect. So something that you may have in there is if you have tumor cells. So peritoneal carcinomatosis, metastatic cancer. If you have cells in the peritoneum, it's going to pull water out because you have stuff in the peritoneum that's going to pull water out. Other things include infections and pancreatitis. So that's an exudate. Well, how do we know? If you have ascites, how do we know if it's transudative or exudative? What you can do is you can get a sample of the ascites fluid, the acidic fluid, and you can find out what the concentration is of albumin. And what you do then is you compare it to the serum albumin, the albumin that you have in your blood. And these are concentrations. So you take your serum albumin and subtract your acidic fluid albumin. And this is called your serum ascites albumin gradient. So if you have a high serum ascites albumin gradient, that would be anything above 1.1 grams per deciliter, that's transudative. Well, what does that tell you if it's high? It means that you have a relatively low amount of albumin in the acidic fluid. Well, that's because you have more water in the acidic fluid, because it's transudative. You're pushing water out of the blood. You're pushing non-proteinaceous fluid. Because it's transudative, it's because of pressure. So you're pushing water out into the acidic fluid. On the other hand, if you have a relatively high level of albumin, that's because it's exudative. So that's going to make a lower SAAG. And that's because the cause of an exudate is because you have stuff in the peritoneal space. You have stuff in that fluid. And so while it does pull water in, you have all that stuff, and I say stuff because it can be a lot of different things, because you have all that stuff in the peritoneal fluid, that's going to register with a high acidic fluid albumin, and so it's going to drop this serum ascites albumin gradient. So a high SAAG above 1.1 grams per deciliter is transudative, and a low SAAG is exudative. And you have your differential diagnosis. The number one cause of ascites overall is cirrhosis. It's also the number one cause of a transudative ascites. The number one cause of an exudative ascites is metastatic cancer. The major complication of ascites is something called SBP, spontaneous bacterial peritonitis. You would suspect this in a patient with ascites and a fever. So what do we do for uncomplicated ascites? The first step is spironolactone, 100 milligrams. We see if this works. If it does, you continue treatment. If not, you add furosemide. So spironolactone first. If it doesn't work, add furosemide. If that works, continue treatment. If that doesn't work, you increase dosage up to a certain level. And if that still doesn't work, then we consider it refractory ascites. If it's refractory, then our next step is a paracentesis and sodium restriction. And then if this doesn't work, we start looking towards surgical treatments, which is beyond the scope of this talk here, but TIPS is a possibility. Okay, so remember spironolactone, furosemide, then a therapeutic paracentesis. Question 2. So this is continuing from question 1. We have the same patient. Medical treatment with spironolactone followed by furosemide fails to improve the patient's ascites after 4 weeks. Prior to performing paracentesis, which of the following lab tests is most important to obtain? A, platelet count, B, bleeding time, C, partial thromboplastin time or PTT, D, prothrombin time or PT, or E, serum albumin. Okay, and the answer to this one is D, prothrombin time. So why do we want to get a prothrombin time? Prothrombin time is very likely to be affected by chronic liver disease. In this case, the patient has cirrhosis, alcoholic cirrhosis, the number one cause of ascites, and we're concerned about the prothrombin time being elevated. Anytime a patient has elevated prothrombin time, they're at risk of bleeding with surgical procedures. Well, why not a platelet count? Certainly, if you have a very low platelet count, you're at risk for bleeding with surgical procedures, and that's true. Really, any profound thrombocytopenia, we're talking really here below 10,000 per cubic millimeter, you have a very high risk of complications with surgical procedures, but that's not very likely. You can get thrombocytopenia with liver failure, but it's not going to be that low. So we're not so much worried about platelet count. Bleeding time is really not clinically significant, especially for a patient like this. Bleeding time really measures platelet function and number, so we're not worried about the bleeding time. Partial thromboplastin time may be prolonged in a patient with liver failure, but it's not so much associated with an increased surgical risk. And then serum albumin is really not important here at all, especially because here we are worried about the possibility of surgical complications. And in all likelihood, you already got a serum albumin in the process of diagnosing the cause of this patient's ascites. So we're most concerned about getting a prothrombin time now. Serum albumin would be important for the diagnosis of why this patient has ascites, but we kind of already know the cause of this patient's ascites already. So it's prothrombin time, and the reason, as I said, is to evaluate this patient's risk of complications. And the big complication with paracentesis is bleeding, as well as there's a minor risk of perforation of the viscera. So the paracentesis is a diagnostic or therapeutic removal of acidic fluid. Some indications include new onset or refractory ascites, which is this patient, suspicion of spontaneous bacterial peritonitis, respiratory compromise, and abdominal pain or pressure associated with ascites. The parameters that we get with paracentesis when we're evaluating the acidic fluid is the appearance. Is it clear? Is it yellow? Is it cloudy? Is it bloody? White blood cell count, including the PMN percentage. The acidic fluid albumin concentration, and that's to measure the SAAG. The total protein, the culture, and then some other things which can include glucose, amylase, TB testing, alpha-fetoprotein. The last is looking for cancer. Complications include leakage, hemorrhage, infection, and bowel perforation. So this is the coagulation cascade. This gets disturbed with liver failure, and this is why we are worried about the possibility of bleeding in a patient who has liver disease. This is something that I found online. You can look this up. But this is when you do a paracentesis, this is all the things we're looking at, and it kind of gives you an algorithm of how you can arrive at a working diagnosis. Note the importance of looking at the appearance of the fluid can give you a pretty good idea of what may be going on. And then we're also concerned definitely about the white blood cells. If the white blood cells are high and you have a high PMN count, we're looking more at infection. If the white blood cells are low or normal, you're looking more at anatomic issues, heart issues, or kidney issues. So I'm not going to go into all the details of this, but here it is for you. Okay, question 3. Moving on to a new patient. We have a 43-year-old woman presenting to your clinic complaining of intermittent abdominal pain over the last 6 weeks. She says that the episodes usually follow meals and are especially worse with heavier meals. The episodes last about 10 to 15 minutes. They're somewhat relieved by laying still and are worsened with pressure. Acetaminophen and antacids do not help. Sometimes she feels nauseous with the pain, but she's never vomited. The pain is epigastric and wraps around the right side and sometimes up the back. The episodes do not coincide with her periods, which are regular. She denies alcohol and tobacco use. Her BMI is 36 kilograms per meter squared. Vitals are within normal limits. Physical exam is unremarkable. Which of the following is the best next step in the management of this patient? A. Abdominal X-ray. B. Abdominal CT. C. Abdominal sonography. D. ERCP, which is endoscopic retrograde cholangiopancreatography. Or E. Elective laparoscopic cholecystectomy. Alrighty, so what I want you to do is come up with the presumptive diagnosis and then tell me what you would do for this presumptive diagnosis. So the answer is C, abdominal sonography, and our presumptive diagnosis in this patient is biliary colic. Why biliary colic? Well, first of all, she's got intermittent pain. That's colic, intermittent pain that comes and goes. Well, what is this pain associated with? Remember, when you're taking your history and you have a patient with pain, you always want to know, is there anything that you think leads to this pain? Is there anything that relieves the pain? How bad is the pain? Where is the pain? Does the pain radiate? What's the nature of the pain? How would you rate the pain on a scale of 1 through 10? What makes the pain worse? Remember, all that stuff that they teach you in medical school. Well, we find out that the pain is worsened with heavier meals. That's classic gallbladder. Not only that, but when she has the pain, it's kind of in the middle, but it wraps around to the right side. Well, that's gallbladder too. It also radiates up the back. That's also gallbladder related. So we know, for the most part, that this is gallbladder related. These episodes last 10 to 15 minutes. They follow heavier meals. This is classic biliary colic. It's almost certainly not a cholecystitis, because if she had cholecystitis, she'd probably have a fever and the pain would be ongoing. She'd have a positive Murphy sign, and so there would be a remarkable physical exam. Cholecystitis pain is ongoing. You have an infection. It doesn't go away. Biliary colic comes and goes. They're both caused ultimately by stones. But with biliary colic, you don't have an infection. You just have stones that block the neck of the gallbladder or the cystic duct. But it's intermittent. She also has the classic risk factors for biliary colic or cholecystitis, and that is fat, female, fertile, and 40. So she's BMI of 36, well into the obese range. She's fertile. She's got periods. She's not postmenopausal yet. she's female, and she's in her 40s. Now, you don't have to have all those things. You can be a 25-year-old guy and thin and have biliary colic, and so none of these things have to happen, but these are risk factors, so look for them. So I gave you a pretty straightforward case of biliary colic here. The first thing we do in a patient with biliary colic after we're done giving them something for their pain and making them comfortable is we get an abdominal sonography. We're looking for stones, and by far the best imaging test for looking for gallstones is sonography. So you'll get sonography of the abdomen, more specifically the right upper quadrant. You look for stones, you look for sludge. If you see those, bam, you got your diagnosis. X-ray you may see stones, you might not. CT, same thing. Sonography is just way better. ERCP would be a good modality if you have a stone that's that's further down the ducts, because this can be therapeutic. You can actually ablate that stone, but that's not going to be what we do in this case. Cholecystectomy could be a good idea if you have a patient that's just got biliary colic and it's been ongoing for a long period of time and they're just sick and tired of it. You can do an elective lap chole, but that's not where this patient is at yet. What we want to do is we want to establish diagnosis of biliary colic. So biliary colic is abdominal pain caused by intermittent obstruction of the cystic duct due to gallstones. It commonly presents in fat, female, fertile, and 40-somethings. The pain is epigastric to the right upper quadrant and often radiates to the right scapula. The gold standard for diagnosis is an abdominal ultrasound, and an abdominal ultrasound should be undertaken in any patient with intermittent abdominal pain, especially that radiates to the right upper quadrant. So your initial management will be relieving the patient's pain, and that's just your clinical pastoral management of a patient. You want to treat their pain first, provided they're stable. And you can give them NSAIDs like Toradol. You can give them narcotics, but we're kind of moving away from that. An elective cholecystectomy can be undertaken for patients with repeated episodes. So I will just add, sonography has got 95% specificity and sensitivity. It's much cheaper than other imaging modalities, and it doesn't expose the patient to ionizing radiation. And as I mentioned before, ERCP may be appropriate if there's stones that are in the bile duct. Lab tests can give you a hint on that. If there's stones in the bile duct, you may see an elevated ALK-Phos, elevated conjugated bilirubin. So labs may be useful, but if you just go right on to an abdominal ultrasound, you'll be able to determine where these stones are. So this is a stone in the gallbladder. Now this stone may be moving around, so at times it may be sitting in the neck of the gallbladder and obstructing and causing the biliary colic, but it doesn't have to be there. This patient doesn't have pain right now, and so the stone may be back into the gallbladder. I'm not sure if this is sludge here or not. I doubt it, because sludge will usually pool on the bottom. But you may see this kind of echogenic material, and that's sludge. Question 4 gives us a 72-year-old woman presenting to the ED from her nursing home due to 2 days of ongoing watery diarrhea and vomiting. 4 days ago, she was discharged from the hospital where she stayed for 2 days for pneumonia, which was treated and improved with azithromycin. Vitals show a blood pressure of 105/70, heart rate 90, respirations 15, temperature 100.6 degrees Fahrenheit, saturation 97% on room air. Physical exam is remarkable for diffuse abdominal pain to palpation. Stool studies are positive for leukocytes and red blood cells. Abdominal X-ray is obtained and shows you this. So you can take a look at this, you can pause it, and think of what you see here. Okay, moving on. Physical exam, okay, I said all that. Stool studies are obtained. Which of the following is a major risk of this patient's presumptive condition? Okay, so I expect you to know what the presumptive diagnosis is. We don't know for sure yet. There's more things we can do. But figure out that presumptive diagnosis. And now, what is a major risk of this patient's presumptive condition? A. Fistula formation, B. Colonic perforation, C. Malabsorption, D. Hemorrhage, or E. Intussusception. The answer here is B. Colonic perforation. So what does this patient have? So going back here, you can see that this is more than likely pseudomembranous colitis. So there is diffuse edema, particularly in the transverse colon. You see what here is called thumbprinting, where you've got edema within the wall of the large intestine, and then it's also dilated. This is associated with colitis, and in particular here, based on the patient's history, that she's got a fever, that she's been on antibiotics, that she's got watery diarrhea and vomiting, that she's got abdominal pain, we here are concerned about antibiotic-associated colitis, particularly Clostridium difficile colitis. So pseudomembranous or C. diff colitis is a diarrheal illness caused by colonization of the colon with Clostridium difficile. C. diff is a gram-positive anaerobic spore-forming bacillus. Basically what happens here is you take an antibiotic, the antibiotic wipes out your normal flora in the large intestine, and then C. diff, if a patient is exposed to it one way or another, that goes in and takes over the large intestine. Normally it can't do that because it's outcompeted by the normal flora, but if you wipe out the normal flora, C. diff can come in, it can colonize, and then it produces toxins leading to inflammation, and then that pseudomembrane forms. The pseudomembrane is going to interfere with normal absorption, and that can cause a mild to moderate watery diarrhea, ultimately causing cramping abdominal pain because of the edema, anorexia, and malaise. Now notice here that the complication is colonic perforation, and that's due to, it's basically due to a loss of integrity of the bowel. Now you may say malabsorption, and there is some small degree of malabsorption, but it's minute. And so it's not a major risk of the patient's condition. Colonic perforation can be deadly, and so that's the big thing that we're worried about. Hemorrhage, no. Fistula formation, no. Fistula formation is associated with something like Crohn's disease, which is an inflammatory condition of the bowel, but that is not going to be associated with C. diff colitis. And then intussusception is not the case here. So the major risk I should say the diagnosis for C. diff colitis, if you suspect it, is to get a stool toxin assay for C. diff. And if you do get imaging, CT is preferred to X-ray, but I showed you the X-ray here. You may get an X-ray looking for free air if you're concerned about a perforation. Here you have a patient with diffuse abdominal pain. If the patient were to have perforation, they would have rigidity and guarding and stuff, and so an X-ray can be good. A CT is better, but an X-ray can be good to look for free air. You may get an X-ray on the test. You may get a CT. I would suspect you get an X-ray because USMLE does not give CTs as often as they give X-rays. They don't expect your radiology knowledge to be that advanced, but they do expect you to know some basic X-rays. So I would know this thumbprinting sign and then the dilation of the transverse colon. Major risk factors include antibiotics within the last 3 months. It takes a while for that for the large intestine flora to reestablish itself. That's why a lot of times now they give probiotics when you're taking antibiotic therapy. And this is particularly the case with fluoroquinolones, cephalosporins, and clindamycin. Exposure to a healthcare environment. Why? Because C. diff is everywhere, especially where there are sick people. So nurses, doctors are at a higher risk for developing this, especially if they're also on antibiotics. And then acid-suppressing medications. That would include things like proton pump inhibitors and H2 antagonists. So the major complication, as I said, is colonic perforation, and the treatment is to stop the offending antibiotics and start oral metronidazole. It needs to be oral so it can get into the colon and affect the C. diff. If the patient does not respond to oral metronidazole, you can give vancomycin, and that usually will do the trick. So metronidazole first, then vancomycin. Okay, question 5. We have a patient here with who is a 78-year-old man and presenting to the clinic with his son because of repeated falls of unknown cause. And these have been happening a few times a week for the last 3 weeks. The patient reports that when he falls, he feels a sudden weakness in his legs, causing his knees to quote-unquote buckle. After a couple minutes on the floor, he is able to get up and walk again. He adds that sometimes he feels like the room is spinning, but this happens independent of his falls. So sometimes he doesn't have that sensation of spinning, and he falls, but so there's no association. He doesn't always feel that spinning before he falls. He denies lightheadedness or loss of consciousness during the episodes. Vitals are within normal limits. A bruit is appreciated over the left carotid artery. There are no signs of head trauma. There is no rigidity or bradykinesia. Deep tendon reflexes are normal. Cranial nerves 2 through 12 are intact bilaterally. Medications include hydrochlorothiazide and lisinopril. Which of the following is the most likely explanation for this patient's symptoms? A. Vertebrobasilar insufficiency. B. Postural hypotension. C. Benign paroxysmal positional vertigo. D. Labyrinthitis. Or E. Carotid artery stenosis. Alrighty, so the answer to this is vertebrobasilar insufficiency. So this is a tough one. Now, this patient does have vertigo, right? So he does complain of the room spinning. However, there is a huge differential for vertigo, and it's easy to go to some of the more common things. Now, the most common cause of vertigo is BPPV. That would be answer C here. However, there's some things that make us think that this is not BPPV. Why? Because he's falling even when he's not having vertigo. That should not happen. With BPPV, if they fall, it should only happen when they have vertigo. Because when they're not having vertigo, why would they be falling? They shouldn't be falling at all. Also, when he falls, it takes a couple minutes before he's able to get up and walk again. With BPPV, when they fall down, they should at least be able to get up, even though they may still be dizzy. So that causes us to think that this is something else. And vertigo can be a lot of things. It can be labyrinthitis, it can be vestibular neuritis, it can be Meniere's disease, and it can be vertebrobasilar insufficiency. Vertigo is one of the hallmark symptoms of vertebrobasilar insufficiency. So why not? So we think that it's not BPPV for reasons that I mentioned. Well, why not labyrinthitis? Another cause of vertigo. With labyrinthitis, typically you'll have hearing deficits, and so that's probably not the cause here, because we don't see anything about hearing deficits. Postural hypotension tends to be when you stand up after sitting down, or particularly in older patients, when they get up out of bed, they'll fall. That's not the case here. He doesn't have lightheadedness. And then, so really we're between vertebrobasilar insufficiency and carotid artery stenosis. And it's really only vertebrobasilar insufficiency that will give you that vertigo. What else do we have here that's important? He's got this where he says he feels a sudden weakness in his legs, causing his knees to buckle, and then he falls down. So what this is it's a sudden drop. Okay, and I'll go on here. These are drop attacks, and that is a common manifestation of vertebrobasilar insufficiency. So basically what's happening is there's an insufficiency that's affecting the pyramidal tracts, and that's causing sudden weakness of his legs. So this is a TIA. This is a transient ischemic attack, which lasts for a short period of time. So it's like what they call a mini stroke. And so that is why he's not able to get up right away. He's got to wait for the blood flow to restore itself before he's able to get up. So the fact that it lasts for minutes as opposed to it's sudden and then he's able to get right back up really makes us suspect a TIA. And so it's vertebrobasilar insufficiency. Carotid artery stenosis typically doesn't cause these drop attacks. Usually they'll cause some motor and sensory symptoms, which can be arms, it can be legs, but it'll also, in many cases, cause an aphasia as well, especially if it's affecting the left side of the brain. So carotid artery stenosis will usually not do this. So vertebrobasilar insufficiency is decreased blood flow in the posterior circulation of the brain. Remember, there are some overlaps with labyrinthitis, vestibular neuritis, and BPPV, but those things will not give you those drop attacks, and usually those things will also give you a prolonged vertigo, which will always be associated with the falling. Remember that the posterior circulation is back here before your circle of Willis. The vertebral arteries give rise to the basilar artery. The basilar artery will then split into your, it's not listed here, but the anterior inferior cerebellar artery, the pontine arteries, the superior cerebellar artery, and the posterior cerebral artery up here. The most common manifestations of vertebrobasilar insufficiency are vertigo, diplopia or visual changes. Sometimes they may say their vision is turning gray, but usually it's diplopia, and then these drop attacks. Compared to anterior circulation defects, so issues with the carotid artery, the patients with vertebrobasilar or posterior insufficiency are less likely to display hemiparesis and hemisensory deficits, and they do not display aphasia. Remember, that's towards the front of the brain in Broca's area. The vertebrobasilar insufficiency is also known as beauty parlor syndrome. Why? Because back in the 1990s, a physician noted that he had some patients that they would get this when they would go to the beauty parlor and they put their necks back to have their hair washed. And notice that when you put your neck back into one of those sinks, you have to extend your neck. And that's going to compress these vessels. And so if you already have some blockage of these vessels, and I will add that the number one cause of blockage leading to vertebrobasilar insufficiency is atherosclerosis. If you already have some blockage, then compressing your neck by extending it is going to lead to insufficiency. And so when they put their neck back to get their hair washed, they would have these symptoms. So it may be worsened with neck extension. The diagnosis for vertebrobasilar insufficiency is going to be head CT and angiography. I'll also note that vertebrobasilar TIAs, compared to those involving the carotid arteries, they tend to last for a shorter period of time. Median is about 8 minutes as opposed to about 14 minutes. So the anterior insufficiency, that involving the carotids and those vessels that lead off the carotid, MCA, ACA, will lead to hemi or monoparesis, hemisensory deficit, headache. Aphasia is one of the more specific symptoms, and visual field defect. The posterior circulation vertebrobasilar insufficiency is vertigo, visual field defect, drop attacks, ataxia, altered consciousness, diplopia, and hemi or monoparesis. The ones that are bold-faced are more specific to these two circulations. So what are we ultimately going to do for this patient? Well, we want to, we know what the likely cause is. It's atherosclerosis. We want to do a cardiovascular workup on this patient. First, we want to look at his risk factors. Certainly age is one of them. Hypertension is a possibility. Is his hypertension controlled on the medications that he's on? He's on hydrochlorothiazide and lisinopril. Want to make sure that he's controlled on that. Diabetes, smoking. Does he smoke? If so, he needs to stop. Hyperlipidemia. We want to get a cholesterol panel on him. And then family history. So really you want to focus on getting that lipid panel. If the lipid panel comes back high LDL, which it invariably will because, as I said, atherosclerosis is the big cause here, you're going to want to get them on a statin. If you happen to have a younger patient that comes to you, 30s, even 40s, that has a likely TIA. It gets diagnosed on CT or angiography. You probably would be well advised to get a hypercoagulability panel, looking for things like lupus anticoagulant, anticardiolipin antibodies, protein C, protein S, antithrombin 3, factor V Leiden. That may be useful because there may be something else behind this patient having a TIA at such a young age. Treatment is going to be modifiable risk factors, as previously mentioned. You can put them on antiplatelet drugs, you can put them on anticoagulants. If none of these things help, or if you have an angiography that comes back with severe issues, you can consider surgical management like stenting and angioplasty. You'd want to be in consultation with a vascular surgeon or a neurosurgeon before, obviously, you go about doing that. And you probably won't do it. It'll probably be a surgeon. Unless you are a surgeon, then you may do it. Question 6 gives us a 35-year-old man who presents for his annual health maintenance examination. He is generally in good health, aside from occasional upper respiratory tract infections over the last several years, which have never required intervention. He works as a mechanical engineer, is married and monogamous. He smokes 1 to 2 packs per day for the last 15 years. He drinks 1 or 2 beers per week and denies recreational drug use. He's 5 feet 10 inches tall and 195 pounds, which equates to a BMI of 28 on the nose. Vitals are within normal limits and physical exam is unremarkable. As part of routine care, you counsel him regarding smoking cessation. Which of the following is the most appropriate course of action? Is it A, recommend nicotine replacement therapy, which includes gum or patches? B, recommend varenicline therapy, which is Chantix, by the way. C, recommend group therapy. D, ask patient if he wishes to stop smoking. Or E, set a quit date and follow up to discuss options at that time. Alrighty, so the answer to this one is D, ask the patient if he wishes to stop smoking. So, where do you come up with this answer? First of all, you should know that if you're taking the USMLE, I'm not exactly sure about the tests in other countries, but for the USMLE, you need to be intimately familiar with the health maintenance examination. This is just the routine physical exam. Patient comes in, no complaints, they're just coming in for their yearly physical. Always, 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 you need to ask the patient, do you smoke? Do you drink alcohol? Do you do drugs? Because if the answer to any of those questions is yes, then you need to counsel them about quitting. Now, if you drink 1 or 2 beers per week, not a problem. Okay, if it's 1 or 2 beers per day, probably not a problem. But if it's 5, 6 beers a day, that's a problem. Okay, so use your judgment here. But any smoking, any recreational drug use, you need to counsel them about quitting. Now, I will just add here that this patient has a BMI of 28, so another thing that I could have made this question about is counseling him about diet and exercise. But in this case, we're focused on his smoking, and for good reason, because smoking is a major cause of morbidity and mortality in this country. So we want to get him to stop smoking. What's the first thing we need to ask? We need to ask, do you want to stop smoking? Because if he does not want to stop smoking, you can recommend nicotine replacement therapy, you can recommend Chantix all day, he's not going to do it. So you need to ask if he wants to stop smoking. At that point, then you can set a quit date. Okay, when do you want to quit? And it needs to be up to the patient. It needs to be up to the patient. Maybe he wants to quit by New Year's. That's his New Year's resolution. Or maybe his wife is pregnant and he wants to quit before the baby is born. By the way, little pearl here. Baby is exposed to smoke. What's one of the major problems with that? What can happen to baby exposed to smoke in infancy? Sudden infant death syndrome if they're smoking in the house. So it's a good reason for parents to quit, new parents. That aside, you need to know if he wants to stop smoking. This is important not only for step 2 CK, the clinical knowledge portion, which you're probably studying for right now, but also step 2 CS. You need to ask every single patient you encounter, do you smoke? Do you drink alcohol? Do you do drugs? If they smoke, you need to ask them, are you ready to stop smoking? Do you want to stop smoking? If the answer is no, you can go ahead and say, well, if you do wish to stop smoking, give me a call. We have options for you. If the answer is yes, then you need to ask them, when do you want to quit? And here are some options. Nicotine replacement therapy. You can do gum or patches. Varenicline, Chantix, good drug. There are some side effects, but it's a pretty good drug. It's been around for a while now. Group therapy usually is reserved for patients who are refractory to some of these other conventional methods like nicotine replacement and varenicline. And then patients who are really refractory, even to group therapy, you can set them up with a psychiatrist who may recommend something like Zyban, bupropion, which is a little bit of a steeper step to tread because it's got antidepressant properties, and you run into some issues with if the patient has a history of seizures. But a lot of times family practice doctors feel comfortable recommending that one too. But psychotherapy can be useful. But all of this stuff is only useful if the patient is ready to stop smoking and they're ready to set a quit date. All right, so that being said, I will just add as a footnote here, there was a study that just came out tracking people who had stopped smoking and went on electronic cigarettes, which you might be aware of. They're just these little electronic battery-powered devices, and they use a vapor that is, the fluid is mostly is nicotine and water and glycol. There is some evidence that this is useful for patients to gradually stop smoking. However, we don't know the risks to benefits yet, so that is not currently not a recommended means to quit smoking. However, that may change in the next 10 years as more research comes out on that. If a patient does want to use that, I would feel comfortable personally saying that's probably a good idea because there's so much fewer carcinogens in the vapor. You don't run into the tar and the formaldehyde more than likely that you would run into with cigarettes. But that is anecdotal at this point. All right, so upper respiratory tract infections, very common quote-unquote side effect of smoking, of heavy smoking. And so that probably has to do with his smoking. We're probably not looking at anything else there aside from that. So smoking, approximately 18% of Americans smoke cigarettes, and smoking-related illnesses, such as lung cancer and COPD, cost the U.S. economy more than $300 billion every year. That's a lot of money, considering what's the national debt. It's like $20 billion. Probably a little bit more than that after Trump's tax bill. So $300 billion is nothing to shake a stick at. If everybody quits smoking, we would save $300 billion every year. The life expectancy for smokers is at least 10 years shorter than non-smokers. And remember some of the morbidities of smoking, something you'll want to counsel the patient on. If you keep smoking, you raise your risk of lung cancer, you raise your risk of heart disease, you raise your risk of stroke. And of course COPD and emphysema and all of that nasty stuff that you can avoid if you stop smoking. So these stages of change kind of go into the question that we had. So pre-contemplation. This is a patient who's in denial. They're not even considering change. Sometimes they recognize that they should maybe stop, but they don't desire to stop because they feel like whatever effort they put into it is going to be fruitless. This is pre-contemplation. They're not even considering quitting. Notice it's called pre-contemplation. That's kind of optimistic. It says maybe someday they'll stop, or maybe someday they'll be contemplating stopping. And that's the way we need to approach every patient. Even if a patient tells you one day they're not considering stopping smoking, the next time they come in, you got to ask again and again and again. You're going to sound like a broken record, but it's something that you have to do for every patient. Contemplation is when the patient begins to consider changing, but they don't have a particular plan yet, but it's in their mind. Okay, so hopefully after you've seen this patient several times, you've planted this little seed in their mind that they need to quit, and eventually that seed begins to sprout and they begin to have contemplations of stopping smoking. And at this point, this is when you start giving them their options. So we have Zyban, we have Chantix, we have over-the-counter nicotine patches and gums. So you give them their options. Preparation is when the patient has decided to change. They have figured out what they're going to do. They've made a plan, and Now they're setting a date and they're preparing to begin the change, but they haven't done it yet. And then that quickly leads into action, where the patient is actively refraining from the undesirable behavior. They've quit smoking and they're participating in this plan for the behavioral change. And then at this point, really action and maintenance kind of come together, where they've stopped smoking, they've stopped drinking, and a lot of times for alcoholics, this is when they continue going to their AA meetings. If you go to an Alcoholics Anonymous meeting and you sit in and watch, you'll see that some of those patients have been alcoholics, have been abstinent from alcohol for 15, 20 years, but they still say, my name is so-and-so and I'm an alcoholic. Well, why are you an alcoholic if you haven't smoked or you haven't drank in 20 years? Because that's part of maintenance. They recognize that they have a problem and it's part of their maintenance to prevent themselves from going back into alcoholism, that they recognize they're alcoholics. They can't drink. So that's maintenance. And then relapse prevention is also part of that. Staying away from other smokers, perhaps, staying away from other drinkers, staying away from bars if you're an alcoholic is part of relapse prevention. As I said, the first step in smoking cessation counseling is determining the patient's willingness to quit. And that's what I hope you get out of this, aside from the fact that you need to ask them every single time they come in if they're willing to stop smoking. Okay, question 7 gives us a 36-year-old woman presenting complaining of fatigue over the past 2 months. Review of systems is also notable for symmetric joint pain of her wrists and fingers for the same duration, and other nonspecific aches and pains, which we'll say maybe has been lasting a little bit longer. She's previously been in excellent health and has received all recommended immunizations. She denies sick contacts. Physical exam reveals a red scaling rash on the dorsum of both hands, which she says preceded the joint pain by a few months and which was diagnosed as eczema and for which she takes topical hydrocortisone. Past medical history is significant for 3 spontaneous abortions. Vitals are within normal limits. Laboratory workup reveals a normocytic anemia and prolonged PTT. Remainder of CBC, PT, and bleeding time are within normal limits. Which of the following would be a useful additional investigation in this patient? Is it A, anti-TPO, B, anti-Rho, C, antiphospholipid antibody, D, rheumatoid factor, or E, anti-mitochondrial antibody? Okay, so you might want to go back and read this again. You can pause it here. This is a little bit more complicated question than the last one. And the answer to this is C, antiphospholipid antibodies. So we got this woman coming in complaining of fatigue. All right, that is a humongous differential. So anytime somebody comes in with fatigue, you're going to be getting a really good history, really good review of systems. You want to make sure you know as much as you can about this patient because there are so many different things that can cause fatigue. Luckily for you on the USMLE, on questions, board questions, you're going to get the information you need. So we find out that she's got joint pain, symmetric joint pain, accompanied with a rash. When you have joint pain and a rash, you're thinking of rheumatic autoimmune issues, maybe something like psoriatic arthritis, rheumatoid arthritis maybe. She's right about at that age where patients start showing up with rheumatic issues, 20 to 30 years of age, 20s and 30s. And she's a woman. That raises her risk too. So in addition to this, and this is why it's always important to get a good history, she's got this interesting OB history. Now, if you're approaching step 2 CS, and I bring this up again for the second time, it's very important that you get good histories on these patients because a lot of times they'll have something positive in their history. And we don't often think to get OB histories on women unless they're coming in with something, OB related, but it's very important. And in this patient, we got some very important information. She's had 3 spontaneous abortions. That's not normal. Okay, it's not normal. 1, yeah, sure, normal. But having multiple is not very normal. There's usually something behind that. Maybe a chromosomal translocation, pretty common. But there's usually something behind that. And now we put all these together, and then you add this prolonged PTT. Well, first of all, what does this look like? You got a woman in her 30s with a rash and with joint pain. We're thinking of rheumatic issues. All right? We don't know what it is necessarily, but we're thinking rheumatic issues, possibly lupus. And then you put, in addition to this prolonged PTT, a normocytic anemia consistent with rheumatic disease, and these 3 spontaneous abortions. We're looking at something called antiphospholipid syndrome. And indeed, the 3 spontaneous abortions, multiple pregnancy losses, is consistent with antiphospholipid syndrome, but the big one here, the big giveaway, is a prolonged PTT. Now, antiphospholipid syndrome is a procoagulative syndrome, meaning that that syndrome puts them at greater risk for developing clots and throwing them, getting DVT, pulmonary embolism. But with antiphospholipid syndrome, you'll have a prolonged PTT, and that has to do with the nature of the antibody. In vitro, it causes a prolonged PTT, but in vivo, it means that they're more likely to have clots. Kind of a paradox, but that's how it works. So one of the antiphospholipids that we look for is called lupus anticoagulant. Now, don't let that name fool you. Lupus anticoagulant is not an anticoagulant. It's only an anticoagulant in the laboratory, but in the body, it is procoagulative. And so patients with a positive lupus anticoagulant are actually more likely to have clots. And lupus anticoagulant is one of the antiphospholipid antibodies, along with anticardiolipin and then another one called anti-beta-2 glycoprotein, which we'll talk about in a little bit. So this is antiphospholipid syndrome in all likelihood. Why not the anti-TPO? What is anti-TPO? What are we looking for it in? We're looking for anti-TPO perhaps in a patient who has all this, many of the symptoms of hypothyroidism. In a patient about this age, we think about the #1 cause of hypothyroidism. In the US, it is Hashimoto's thyroiditis, an autoimmune condition in which anti-TPO would be the best choice. In the developing world, more common cause of hypothyroidism would be iodine deficiency, but this is the US MLE, and so we're looking for the most common causes in the US. Anti-Ro, what is that associated with? Sjogren's syndrome, 90%. You want to associate anti-Ro and anti-LA with Sjogren's syndrome. It's got about a 90% specificity and sensitivity. Yes, it can be positive in lupus, but you should associate anti-Ro and anti-LA with Sjogren's syndrome. Rheumatoid factor, rather nonspecific. You'll order it when you suspect rheumatoid arthritis. It can be positive in a lot of different things. Not a very great, lab to get. It's, like I said, not very specific, but it can be. It is often positive in patients with RA. An antimitochondrial antibody. What is this associated with? Primary biliary cirrhosis. This patient doesn't have any of those symptoms. Okay, so this is antiphospholipid antibody. Antiphospholipid antibody is the marker you're looking for, the family of markers you're looking for. In your lab, you may order an antiphospholipid antibody panel, or you may have to order all 3 of them individually. So this is antiphospholipid syndrome is what we suspect this patient has. Okay, now this is a classic USMLE question. They'll give you a patient, you make a choice, and then it'll tell you beneath it, once you select your choice and click next, then you can't go back. So following up, it tells you antiphospholipid antibody assay is positive. Based on this patient's history and lab findings, which of the following is this patient in most imminent risk for? A, thrombosis, B, hemorrhage, C, glomerulonephritis, D, pericarditis, or E, pulmonary fibrosis. And now I am kicking myself. I pretty much gave the answer away to you when I explained the last question. So hopefully you knew this anyway. You knew this about antiphospholipid syndrome. The answer is A, thrombosis. So why not hemorrhage? Well, hemorrhage would be a trick answer because the PTT is prolonged. And you think, well, the PTT is prolonged, she's not clotting, therefore she must be at risk for hemorrhage. And that is exactly the wrong answer. So you think PTT prolonged, that's going to cause you to bleed, but in fact the PTT is only prolonged in vitro. In vivo, she's actually more likely to have clots. So hemorrhage is out. Glomerulonephritis can be a complication of lupus. It can also be a complication of antiphospholipid syndrome. As far as antiphospholipid syndrome, though, it's more likely to be a thrombotic microangiopathy. So she may be at risk for this depending on whether or not she's got lupus. She probably does. But glomerulonephritis is not an imminent risk in this patient as long as we treat her lupus or whatever she's got. Pericarditis can be associated with both, but again, not an imminent risk. And then pulmonary fibrosis is not. So the answer is thrombosis. You should know that antiphospholipid syndrome, the major problem is thrombosis. That is, they're pretty much synonymous, antiphospholipid syndrome and the potential for thrombosis. You need to marry those two together. All right, so antiphospholipid syndrome is an autoimmune disorder resulting in a thrombophilic state. It is acquired and it is associated with lupus, but it may also be associated with other autoimmune disorders. Lupus is just the most common to be associated with antiphospholipid syndrome. Antiphospholipid syndrome can also be primary, meaning that a patient just has antiphospholipid syndrome. They just have maybe anticardiolipin antibodies circulating. Where you want to look for this then is a patient who's 30 years old and has a stroke, or is 26 years old and has a DVT and comes in short of breath and they have a pulmonary embolism. That would be a patient where you'd want to check for antiphospholipid antibodies because that can cause you to throw a clot. The major manifestations of antiphospholipid syndrome are vascular thrombosis and gestational morbidity, recurrent pregnancy loss. In these patients, maybe they do go on to deliver babies, but they had preeclampsia or eclampsia. Usually it's going to be severe preeclampsia, but look for that in their history. So you did have babies, maybe you had a spontaneous abortion. Well, what about your other pregnancies that were maybe successful? Did you have any complications? Look for that, preeclampsia or eclampsia. And then intrauterine growth retardation. Maybe the baby was small for gestational age. What do all of these have in common? They all have in common the fact that they are placental issues. So recurrent pregnancy loss. Well, if you're throwing clots to your placenta, you can run into problems, obviously. Preeclampsia and eclampsia are known to be placental-related issues, but we don't really know the pathogenesis exactly. It's very poorly understood. And then intrauterine growth retardation. Obviously, if you're not getting enough blood to the placenta, baby's not going to grow appropriately. All right, so look for gestational issues in their history. Also, with intrauterine growth retardation, you're also looking at placental insufficiency as the cause. So perhaps that was noted on her OB workup when she had her neonatal stress tests and stuff like that. Okay, so getting away from OB, which is one of my more favored topics. The presence of autoantibodies. That is going to be present in antiphospholipid syndrome by definition. There are 3 different ones that you may look for. On the USMLE, you may be thrown one of these 2. Anti-beta-2 glycoprotein is a little bit less common, but lupus anticoagulant and anticardiolipin are commonly thrown around. These are antiphospholipid antibodies. They're under that class. So look for lupus anticoagulant and anticardiolipin. These are associated with antiphospholipid syndrome. The labs, if you get labs in a patient with antiphospholipid syndrome, you will see an elevated PTT. You may see a thrombocytopenia, and then of course you're going to see positive autoantibodies. Interestingly, patients with antiphospholipid syndrome will have false positive, many of them will have false positive VDRL and RPR. So if for some reason you were getting that and it came back positive, but they had no reason to have a history of syphilis, it may be something to consider. Kind of a little piece of trivia, USMLE may or may not throw that out there for you. The management for antiphospholipid syndrome is individualized. Many of these patients will not need therapy. However, you will want to control risk factors. So anything else that raises your risk of thrombosis is going to have a multiplicative, synergistic effect on their risk of developing thrombosis. So if they're on oral contraceptives, they probably shouldn't be. If they smoke, they definitely shouldn't be. If they have high blood pressure, you want to control that really well. If they have high cholesterol, you want to control that with statins. So control risk factors, because they're already at risk for clotting. You want to minimize anything else that may raise the risk, because like I said, those risk factors will multiply their total risk. Aspirin may be a good idea if they can tolerate it. There's some physicians that if they can't tolerate aspirin, you could put them on clopidogrel. And then prophylactic anticoagulation will be needed during hospitalizations or surgeries or anytime there's prolonged immobilization. But anticoagulation long-term will probably be needed in any patient with a history of having a thrombosis. So if they have a history of DVT or they have a history of stroke, they'll need to be anticoagulated. Usually do an INR between 2 and 3. You may go higher than that, but that's really outside the scope of step 2 and step 3. Okay, question 9. We have a 44-year-old man presenting to the ED for worsening lethargy over the past 2 days. Again, we get a fatigue patient, long differential. His wife says that he's been quote-unquote out of it, but this morning refused to get out of bed and that he's not been himself. The wife denies patient has suffered any trauma and he has otherwise been quite healthy. Vitals show a blood pressure of 88 over 53, yikes. Heart rate of 120, temperature of 102.9 degrees Fahrenheit, respirations of 18 with a saturation of 97% on room air. Physical exam is notable for obtundation and a wooden splinter in his right calf, which is exquisitely tender. The calf is exquisitely tender and is also erythematous. There is associated edema extending down the right ankle. Fluids are started, good idea, and blood pressure increases to 100 over 70. Labs reveal leukocytosis, elevated AST and ALT, and elevated creatinine kinase. Blood cultures are pending. Which of the following is the most likely diagnosis in this patient? A. Rhabdomyolysis, B. Necrotizing fasciitis, C. Cellulitis, D. Osteomyelitis, or E. Pyoderma gangrenosum. This is a pretty classic picture here. If you have it narrowed down to 2 things, you're probably on the right track. The answer is B. Necrotizing fasciitis. So this patient has an injury, a penetrative injury, and has a fever and a very swollen and painful limb. That is pretty classic for necrotizing fasciitis. So rhabdomyolysis, you'd expect compartment syndrome, kind of looks like that, but we're not really suspecting compartment syndrome and rhabdomyolysis because he doesn't have any risk factors for that. Maybe if he were on certain drugs or if he had a history of injury, we might suspect that. Cellulitis, this really looks kind of like cellulitis, and it can be difficult to differentiate the 2 of those, and I'll get to that in a little bit. Osteomyelitis, more than likely, no. Osteomyelitis is usually associated with circulatory issues or very deep penetrative injuries, and then pyoderma gangrenosum is not the case. I'm not even going to go into explaining that because it'll take too much time, but you can look up what pyoderma gangrenosum is and you'll see that that is not the case here. So this is necrotizing fasciitis. All right, before I go on and explain more, we're going to give a follow-up question here. So question 10, a tentative diagnosis of necrotizing fasciitis is made. Debridement reveals soft tissue necrosis. Blood culture now comes back and is positive for group A streptococci. Which of the following is the most important next step in management? A, IV penicillin G and clindamycin. B, IV piperacillin tazobactam, C, IV vancomycin, D, emergent surgical debridement, or E, hyperbaric oxygen therapy. Alrighty, so our answer to this one is emergent surgical debridement. Anytime you have a patient with diagnosed necrotizing fasciitis or even suspected necrotizing fasciitis, if you got a patient with a wound that looks necrosed, you need to debride it, especially in a patient who's got systemic issues. This guy's got a fever. He's got lab issues. Look at this. Elevated creatine kinase. What does this suggest? This suggests end organ damage. This guy is very, very, very sick. In addition to the fact that he's probably septic. He's got a fever. This guy needs to be treated immediately. And so surgical debridement is our emergent therapy for necrotizing fasciitis. Does he need antibiotics? Absolutely he does. But that's not the most important next step. The most important next step is that you get this rotting tissue out of him. Now, as far as antibiotics, what do you want him on? Penicillin G and clindamycin would be good for this guy, because even though that's not our empiric therapy for necrotizing fasciitis, since it's diagnosed group A strep, clindamycin and penicillin would be your best treatment. This is a wide spectrum, a broad spectrum therapy, and it's really good. Clindamycin is really good for anaerobes, which could be the case here. So IV penicillin G and clindamycin, great for group A strep. If you didn't know the cause, or it's polymicrobial as it is in many circumstances, then you'd want to give vancomycin or linezolid covering MRSA, which is a strong possibility, especially if this was acquired in the hospital, like if it was an operative complication. But then you'd want to also give something like piperacillin tazobactam or a carbapenem or ceftriaxone plus metronidazole. So piperacillin tazobactam itself is not good enough. Vancomycin, likewise, not good enough by itself. So penicillin G and clindamycin would be your preferred antibiotics for this patient. But like I said, rotting tissue in a septic patient, got to get the rotting tissue out. You can give supportive therapy, give fluids and all that stuff, but that's only going to buy him so much time. So emergent surgical debridement. Hyperbaric oxygen therapy, there's been some studies out that say it's good, some studies out that say it doesn't really do much. You can make a similar argument for IVIG, but these are not the most important next steps. The most important next step in a patient with necrotizing fasciitis is get that damn rotting tissue out of the patient and give it antibiotics while you're doing that, ideally. But this is the single most important next step. If you just give antibiotics, you're not going to help the patient. You need to get the tissue out. Hopefully I have rammed that into you enough now. So necrotizing fasciitis is a rapidly progressive inflammatory infection of the fascia, which also affects secondary necrosis of the subcutaneous tissue. So it sounds kind of like cellulitis, but it is worse in that it spreads and it's much more progressive. And necrotizing fasciitis will move along the fascial plane, and its speed of spread is directly proportional to the thickness of the subcutaneous layer. So it'll spread at different rates depending on where it's at. You'll often hear other names thrown around for necrotizing fasciitis, names like dermal gangrene or suppurative fasciitis. You should only run into necrotizing fasciitis on the USMLE, but there is one other name that you'll hear, and this is an important one because it refers to a specific necrotizing fasciitis, and that is Fournier's gangrene. And that's simply necrotizing fasciitis that affects the perineum. So sort of perianal area, scrotal area. And I say scrotal because this usually affects older men. So usually it's going to be older men, maybe bedbound, maybe real bad diabetes. They're at risk for Fournier's gangrene, but it can affect anyone. It can be young people, it can be women, theoretically, but usually older men, Fournier's gangrene. One of the very first patients I saw as a third-year medical student on my internal medicine rotation happened to have Fournier's gangrene, and it was pretty nasty looking. So this is really bad, and this carries a pretty high mortality rate. Necrotizing fasciitis affects about 1 in a quarter million people during their lifetime, which thankfully is on the more rare side, but it's not rare if you got it. It carries about a 15 to 25% mortality rate, and that mortality rate goes up the longer it takes you to diagnose it. So you're working against the clock here. There is a wide range of pathogens that can be implicated. Usually it's a mixed infection, but it can be narrowed down to implicate very specific pathogens. Oftentimes it's going to implicate anaerobes. It can also be Clostridium perfringens, which is a particular bacteria. A lot of times you'll hear Clostridium perfringens, necrotizing fasciitis, and gas gangrene thrown around synonymously, but it's really an inaccurate term. So Clostridium perfringens is a possibility. Another one is MRSA. So MRSA is often implicated in necrotizing fasciitis cases that are contracted whilst in the hospital. So if you have a patient who got surgery and maybe that wound was not sutured properly, and it was left a little bit open, and now MRSA flowed into their wound. That's a very possible vignette that you may get. Group A strep is a possibility, as we saw in our previous patient. And then another one, this was in the news recently. There's this woman that was out, I think she was from Texas, and she was out wading around in water looking for clams to go cook and then eat. And there were some people that said that she may have gotten this infection. She wound up with this red, swollen leg, and eventually it progressed. And I guess she was in the hospital while this progressed, which is really shocking to me because their physician should have figured it out. But eventually, it turned really ugly bluish black, and she died. And so, what was that from? Well, more than likely, what was going on was she shaved her legs, as most women do in this country. And then she was wading around in this water, and it's well known that salt water, especially salt water that's brackish and has shellfish in it, harbors a bacteria called Vibrio vulnificus, which is a major cause of necrotizing fasciitis in patients who are in water and wind up with skin infection. So that's why history is very important. So if you're working in an area where there's a shellfish industry or there's any reason to suspect that the patient was out in the water, you want to know that, because if they were, this is definitely a possibility, and Vibrio vulnificus is probably to blame because that bacteria is found with shellfish. Risk factors for necrotizing fasciitis include antecedent local trauma, which includes surgery. So that's trauma. Surgery, getting cut open, is trauma. But it can also be trauma from stepping on a nail or from getting a sliver. Diabetes, that is going to affect your immune system. Alcoholism, and then immunocompromised state. So a lot of times we hear immunocompromised, we think HIV/AIDS, but it can be also other things like inherited immunodeficiencies and so forth. The symptoms of necrotizing fasciitis are very similar at the beginning to the symptoms of cellulitis. So it starts out as a redness and swelling, which sounds just like cellulitis. You look at these patients, you think, oh, cellulitis, I'm going to send you home with oral antibiotics and you're good to go. Something like cephalosporin. Invariably, if these patients have necrotizing fasciitis, they're going to come back. The problem is, how long does it take them to come back? So eventually, the redness is going to develop into a darkening redness, and eventually it'll become bluish or blackish. And that's a dead giveaway that you have necrotizing fasciitis, but ideally we'd like to catch this sooner. Because this will not remain limited to the fascia and will affect other layers, it can cause a dehiscence of these dermal layers, and eventually that will cause these blisters, these bullae. And we'll see that in a picture coming up. And then ultimately this will cause fever, and because they become septic, systemic toxicity, including end organ failure. What organs are we looking at? We're looking at liver and kidneys for the most part, and especially the kidneys. You get sepsis, the kidneys can go awry pretty quickly, so you look for that elevated creatinine, especially as that creatinine starts sneaking up into the upper 1s and 2s. You really start to suspect that there's something wrong with the kidney. So those are some things that will help you differentiate it from cellulitis, but ideally we like it to not get to that point. So what are some other things that help you separate necrotizing fasciitis from cellulitis? Well, usually with necrotizing fasciitis, it starts out, yes, they're going to have redness and swelling like in cellulitis, but usually the skin overlying a necrotizing fasciitis will be edematous beyond the borders of the erythema. So with cellulitis, you'll usually see the redness and the swelling together. With necrotizing fasciitis, the swelling will extend beyond the redness. Another thing is, of course, the darkened discoloration and the blisters. That typically does not happen with cellulitis. And then the pain level. So I don't know if you've ever had cellulitis. I have. I had an appendectomy about 6 years ago, and then subsequent to that, I got an infection around the wound site. And yeah, so cellulitis is painful, but it's really, to the degree it's painful, it's really like a sunburn. It's uncomfortable, and if you touch it or your clothes are rubbing against it, it hurts. but it's not the kind of pain that will necessarily even send you to the doctor. It's just discomfort. And, it might get worse depending on your pain tolerance, but it's really not that bad. And yeah, you can get a fever, but usually that fever is going to be on the low grade side of things, so 100, maybe 101. Whereas with necrotizing fasciitis, this is going to be really, really, really awful pain. Even when you look at that redness, the patients won't even want you to touch it. And that pain will if you touch it, you'll send them through the roof. So that pain out of proportion to the appearance is more consistent with necrotizing fasciitis. And then another thing that you might notice, but probably you won't because the patients won't want you to touch the affected area, but if you are able to touch it, you may hear that sort of crackling sound, and that is in fact crepitus. And as we're going to see, you can get gas under the tissue, and that's what that popping sound is coming from. So for diagnosing necrotizing fasciitis, the best test for diagnosis is a culture of the tissue. But the problem is a lot of physicians don't culture properly. So if you just take a culture around the wound, a very superficial culture, you ain't going to get anything from that, anything useful at least. You'll get a polymicrobial culture, but all that's telling you is that you got pathogens on the skin. Well, we all have pathogens on our skin, right? So you need to get a culture of areas where you should not have bacteria. And so that's going to be the deeper tissue, and you'll get that during surgical debridement. And that will really help you nail down what the pathogen is. Now, we can also get blood cultures, and that's pretty good because most of these patients are going to have some bacteria in their blood. So getting blood cultures is a good idea, and you should get that prior to initiating antibiotics, as I shouldn't even need to tell you. But if you give IV antibiotics and then you get blood cultures, you really have just ruined your blood as far as knowing what the pathogen is. So get blood cultures prior to initiating antibiotics. As far as imaging can give you a hint. But you don't want to delay surgery in order to get images. So if you've got a patient, you got the surgeon coming down to do debridement, and they're sitting there and you've got a CT suite ready to go, yeah, okay, send them in for a CT. It's nice and quick. MRI, I would probably say no because that can take a while. But yeah, certainly if you can get a CT and you've got the time and you got nothing else to do, then get a CT. Otherwise, don't delay surgery for imaging. The treatment is surgical debridement and broad-spectrum antibiotics, but very importantly, surgical debridement. If you just give antibiotics, you're not going to help the patient out too much. Why? Because this tissue is infected. It's rotting tissue. It's basically a petri dish of bacteria that's spilling into the blood. You give them antibiotics, maybe you might help their sepsis a little bit, I doubt it. But you give them antibiotics, you haven't done anything for that rotting tissue. The antibiotics are not going to treat that tissue. That tissue is rotting and needs to come out. So antibiotics alone are no good. You need to do surgical debridement, but yes, you're also going to give antibiotics to help whatever bacteria is in their blood to get that out of there. So you need to do both. And notice in this question, I asked, what is the most important next step in management? Yes, the antibiotics are good. Penicillin and clindamycin would be good in this patient. But if you just do that, that's not going to treat the patient. You need to do the debridement, but ideally you're going to do both of these together. But the debridement is the most important step because if you just give antibiotics, the patient is going to continue to be sick. So surgical debridement and antibiotics are going to be your next step. You do them at the same time, but the debridement is the most important step in treating necrotizing fasciitis. So hopefully you got that. All right, so some pictures. So notice this looks a lot like cellulitis, and there's really no way to tell it's not cellulitis by just looking at it. You might look for more swelling, you might assess the degree of pain, you might get your laboratory markers, and that can give you a hint as to what this is. But you can see how it's very easy to send a patient off and send them home with oral antibiotics saying, hey, you got cellulitis, take these antibiotics and it'll go away. And then they come back looking like this. And this is not the same patient, obviously, this is an arm, this is a leg, but they come back looking like this, you know darn well what your diagnosis is. This is necrotizing fasciitis. Notice how this is turned color. It's bluish, blackish, very necrosed tissue here. You see you've got some bullae here. And if you were to compare leg to leg, you would see that this is some pretty serious swelling here. And then If you get imaging, CT, MRI, you will notice that there are some pretty obvious abnormalities, and that would be this right here. This is gas. Notice it's black. It's gas. And now if you saw this in the bowel lumen, you'd be like, okay, yeah, that's normal, and it is. But this down here in the fascia and the muscle is not normal whatsoever. And all this is it's the byproduct of bacterial metabolism. It's gas. If you were to compare one side to another, you'd note very obvious abnormalities, as you see here. Note the affected right side, and then this left side, which is normal, you see no gas, and here you see gas. You also see swelling of the surrounding tissue too. So this all needs to come out. This needs to be debrided. This is infected tissue here. One thing I'll also add that I don't think I got to is, and this is the only time you're ever going to hear me say this, but something that you may want to consider getting in addition to all your other labs is a CRP. I am not a fan whatsoever, if you watch my other videos, I am not a fan of these sort of non-specific inflammatory markers. But there's some literature out there that says that a very high CRP, more than 5 times the upper limit of normal, which I believe would be around 150 milligrams per liter, is consistent with necrotizing fasciitis over cellulitis. So a very, very high CRP. So you may want to include a CRP in your lab workup, but I'm a very hard sell on the value of CRP in medicine in general. But you might want to consider, if you're inclined that way, to get a CRP may lend you more towards a diagnosis of necrotizing fasciitis over cellulitis if you really don't know. But I don't lean on CRPs too much. Okay, if you have any questions, please write me a note. Otherwise, I will see you next time.